So we do have to wrap up here, so we're going to bring the moderator, Dr. Rana, right back up for the panel, and we'd like to invite Dr. Katzman and Dr. Walsh back up.
Thank you very much. Thank you very much for that great presentation. Dr. Katzman? Zach? Wonderful. Last 30 minutes of the day, how's everybody feeling? Yeah, we're good? Okay. Do we need a stretch or a... Nobody's moving, are you? Okay. Right, wonderful. So, gentlemen, I'd like to just start very quickly with... okay, well, if we're moving, then I'll come over here too.
Should we move now?
So, Dr. Katzman...
Take away a chair every few minutes.
just to see what happens. Yeah. Dr. Katzman's on a 3-1 score right now in his humor, so we'll make sure that that'll be 4-1, yeah, okay. Gentlemen, I'd like to start just with some of the topics that we were discussing today. And one, just to get an opinion from you in very different patient populations and in different therapy areas. Talking about the topic of stigma and patients and your peers maybe who don't see the benefit or don't understand the benefit of cannabis right now. So if we start with the patient side, like if a patient comes to you and you feel that cannabis in some shape or form would be beneficial for that patient and they're not comfortable with that, how do you tackle that? Evan, I'll start with you if you don't mind.
I guess at this point it's tough for me. Often patients come to me already prepared to have the cannabis talk, right? But if there's a situation in which I do encounter a patient who I believe it would benefit, and it tends to be some of on average, either older population or parents for kids. Yep. So that's where it can be quite difficult. For me, it's always been the exact same approach. Just speak to them honestly, provide information, and I even actually say this line. I said, at one point in the conversation, I say, this is just me as a conduit of information for you. Whatever decision is, that is yours entirely, whether it's for your kids or for yourself. I'm just here to provide information and take with it what you want. I'm here as well if you want to come back and talk about it. And that they either go or they don't, and I think that's really helpful in the end. It's always a positive interaction, whether they take my recommendation or not, and in the end, I'm not attached to the recommendation. I really do genuinely feel that way. Yeah.
Thank you. Dr. Katzman?
No, I would agree with you. I think in my population, there are different groups. One of the groups of patients are the ones who are using cannabis as they refer to it, as one of my clients referred to it, as fun cannabis. And in that population, and they're saying, I'm using it, I bought it at a cannabis store, but the reason I'm using it is because it's doing this for me. And in those guys, I'm talking about the literature, which is pretty sparse, but I'm talking about that there is a benefit. I'm going to use treatments that are better studied as my first line, second line, but often what happens is I get to the now what. So that's that population. And in those cases, I'm going to switch them to a more medical cannabis because I can guarantee what I'm using in my patient is exactly what I'm prescribing. Because if you go to the cannabis store and it says 40% CBT, and you go, well, how do I know? And the answer generally is, well, we don't have quality control to do this. So that really bugs me. Yep. The second aspect is when I've got this patient who's been referred to me and they've failed multiple SSRIs, multiple SNRIs, and you're sort of working through it, and now you're going, okay, now what? And I have a large number of people in my practice who, after kind of going through the classic pathway, and our pathway in our clinic is more extensive and looking for ADHD, looking for bipolarity, ... But subsequently, you come to a point where you go, is there any data here? Particularly in people with chronic trauma and failed insomnia treatments. Those are two places, but also in treatment-resistant anxiety. It's certainly, as I like to see it, it's kind of using a baseball analogy. The cannabinoids need to be warming up in the bullpen. Maybe they come into the game, maybe they don't, but you need them in the bullpen. And that's what I say to my clients. because the cannabinoid system is integrated into everything. As I showed you, it's an ultrafine modulator. And it's interesting because both you and I are talking about the same organ, as we just said, just before we came up here, and modulating the deficits he's dealing with or the deficits I'm dealing with. It's the same neurobiology, and the fact that we're not investigating a huge system in your body doesn't make sense. So the gauntlet is that we're all dropping here is like, why are we not investing in more research? Long answer, sorry.
Nope, great answer. Thank you very much.
Yeah, for me, as a clinical psychologist, and I work primarily in substance use, so there's a lot of stigma there. Is this a recreational drug? Am I backsliding? What are people going to think? What part of my recovery could this be in? And so I always try to just take a step back and help people to, examine what are their values, what are they trying to seek out, what parts of their life are they hoping to improve and move towards, what are they trying to move away from, and then cultivating some curiosity around cannabis, being clear about the risks, and how are we going to track it? How are we going to know if it's going to work? And then because of the stigma and some of the misinformation around cannabis, I like to work by analogy. What is cannabis like? Is it like caffeine? Is it like alcohol? Which substance is it like and in what way? And sometimes when we start the conversation like that, people are able to see ways they might use cannabis, why they would be using cannabis, how would they know if it's working, and how will they know if it's not working, and what are they trying to avoid? And once you create that kind of sort of a rubric or those kind of criteria where someone can make their own decision, then my job is just sort of to walk beside them and help them to explore that with curiosity. One of the reasons I feel comfortable working with cannabis is because I think the harms are very manageable and obvious. So if they start to emerge, we can see that and we can pull it back.
Great answer. Thank you very much. Just stick with you for a second, Zach, if I may. Flipping it from patients to your peers or other colleagues, maybe others who are treating the same patient for other conditions or issues. How often are you seeing that stigma translating to the medical or healthcare professionals?
I think, again, it's by analogy. One thing because people say, oh, it's okay if it's medical, but if it's not medical, then that's a problem, as if there was some kind of big wall that we can identify where it becomes medical and not. And sometimes I'll talk about it as someone getting assistance from an animal, right? We all dogs can be a nuisance, dogs can bite, dogs can cause problems. And if we were to say who can have a dog, I think we start with people with visual impairment and say we can have medical dogs. And you might say, well, what about people who want an emotional support? Can people who are depressed have dogs as well? Okay, maybe then. Is it a medical dog? What if you start playing with the dog? Does it stop being a medical dog then? And what if people just want to have dogs and overall it's a benefit to them and they can make that choice as adults? This is a plant that we've been living beside for millennia. The risks are, I think, pretty well characterized. So analogy goes a long way to combat misinformation because I think there's so many other things that people are doing that share a comparable risk profile that they don't even think twice about. So opening the conversation, cultivating curiosity, and letting people come to their own conclusions, I find is often the best way.
Thank you very much. What about on the psychiatry and neurology side? You get a lot of pushback from colleagues?
You do, and one of the things I'm always struck by is the concept of insanity, where you do the same thing over and over again, and suddenly there's no change. I'm shocked by that same outcome. So what I will say to my colleagues is, do you know how well integrated the cannabinoid system is into everything in your CNS? And where I particularly talk about this is in a non-cannabinoid setting as a launch. I'll say, for example, to rheumatologists, are you aware of how much of an outcome factor the presence of mood and anxiety disorders are? Have you asked yourself why stress plays out in autoimmune disorders? And they'll be like, well, stress causes, you go, you're right, through the HPA axis, but also how do you modulate the HPA axis? And they'll be like, well, and that's where you start to walk through autoimmune, inflammatory disorders, and the role of the cannabinoid system in those systems. And once you establish that there's a logic, then you get people to consider the buy-in. But then the buy-in is CBD is, all I'll prescribe is CBD. There's no value to THC. There's no value to any other cannabinoids. And you've got to kind of walk through the fact that the cannabis plant has, I don't know, 120 odd cannabinoids. Maybe knowing one of them or possibly two, which we kind of do, doesn't mean we know anything. And so it's kind of like you have to go through training wheels to teach people to ride a bike, at which point they're willing to ride faster and harder. And talking to psychiatrists becomes really important. But your industry has somewhat invested, but not enough in psychiatry. And sort of cannabis has become niched. So it's a little okay for you to be prescribing it as a pediatric neurologist, but why am I doing this? And then it's sort of okay, but why not spread? And you've been addressing this in sort of the same way I have, where you're like, okay, let's look at the bigger picture and let's start with neurobiology in the brain and then talk about why we're considering this, because remission rates on SSRIs, for example, in major depressive disorder, about 30%. Anxiety, 30%. Bipolar, managing typical is 30%. Now, just to make it as analogous, things like ADHD are not being well diagnosed and treated because people are scared of stimulants. So the people who are scared to prescribe stimulants, which have DIN numbers, it's not surprising they're scared of cannabis. But the problem is, if your goal is patient wellness, then you'll be a little more aggressive. If your goal is to, do the same old, you'll get same old result.
Thank you
That's
very much.
disturbing.
Thanks, Martin. Different question for you, if I may.
I had such a good answer to that.
Oh, go for it.
No,
Let him go.
mine's just really, really fast though, because as you were
for it.
talking, I'm just thinking. Just imagine a spectrum from like a psychologist talking about analogy, a psychiatrist somewhere in between, then a neurologist going to say like, it's just evidence. You're going to need evidence for the neurologist. Like that's the answer.
Yep, that's the answer.
Yeah.
Great, thank you very much. Just wanted to touch base on one of the cases that you showed, the Rett syndrome cases. It's an area that I've worked in and very interested in. What drives, do you think, the epilepsy bit I understood completely from your talk as much as we know, but what do you think drives the spasticity changes and the behavioral changes with CBD?
You mean drives in terms of improving?
Improvement, yeah.
Yeah, I think that one Rett case though was the case report was specifically referring to seizures though.
I think on the slide it said
and then
that there was an improvement.
Right,
in,
as like a secondary outcome.
Right.
So very much kind of talking about the mechanism of cannabis, again, kind of globally in the brain. The radio as the extra fine tuner is a perfect example, right? So the more I kind of do, I involve myself in cannabis medicine, and I also have involved in psychedelic therapies for neurologic disorders as well. And you start to understand these mechanisms. I'm more fascinated by the fact that we're, like most people, don't move excessively, or they're able just to kind of sit here and be still, right? So because it takes such a degree of perfect regulation for all of you to just be sitting here, like you're sitting here right now, and you're not kind of jumping up out of your seat and moving all around or yelling out loud or saying something like that. To me is far more fascinating and such a bigger mystery than when this goes wrong. It makes sense when it goes wrong. So coming back to answer the question with Rett syndrome, that's what it is. It's you have a mutation that results in anomalous development of the brain that we still fully don't really understand to some degree, but it's the disruption of these fine-tuning mechanisms. And for some reason, and I'm not a Rett syndrome specialist by any means, but just distilling down that pathway, there's at some level the endocannabinoid system is modulating the pathway. So when there's dysfunction or mutation in there, you can imagine that there's a deficiency of the endocannabinoid system adequately modulating that pathway. Therefore, when you supplement it from the plant, you're just really promoting the health of that system. And in doing so, you can kind of stabilize the movement. So I think it's the global way of thinking about it. And that's a global way of really thinking about any of the kind of neurological or psychological conditions that I think are improved by cannabis.
Fantastic. Thank you very much. Moving slightly topics now. So we talked a lot about the different cannabinoids. We talked about obviously the CBD and THC individually or in combination. We talked a little bit about minor cannabinoids. But one thing we didn't talk too much about was method of delivery or a form of delivery. Obviously, oils are super important in your area that you've described. But what about innovation in formulation, innovation in delivery? What kind of things would make you excited for your patients or for your areas? I'll open it up to whoever wants to take that.
I think it's interesting that you asked that. And again, as you're talking, I think about, for example, when you were talking about Rett syndrome and anomalous GABA receptors and the fact that GABA's activity related to the cannabinoid system, soon as there's an artificial separation between what the three of us do. Mm-hmm. And that becomes important when you're talking about that because when you look at receptors and you look at, if you can't get it into the brain, it doesn't matter.
Right.
And this becomes particularly true when you talk about the terpenes. And our group has been doing some research on developing a vehicle to help increase through the blood-gut barrier, which is a huge problem for the terpenes. What happens if we get the terpenes into the blood or even more into the CNS? You look at the potential of 500 chemicals, which at least sitting on a plate have effects on inflammation. We talk about cannabis as if, as my kids would say, as if it's a thing. It's not. Cannabis isn't a thing. It's mucho things. And therefore, what you're using becomes significantly important. But as long as there is not a driver to look at this crazy plant and what it can do. Now, there are going to be consequences that, for the most part, we probably discovered over 5,000 years. But if we can find mechanisms to refine, to target, to get us to get individual parts of the plant getting in, then there's enormous potential here. And yet, government funding, availability of research, that's why a program like this is so important. Raising awareness, raising availability, funding. Because if you think about it, we're all talking about the same organ. And if you were to talk with, say, a cardiologist, the brain bone's connected to the heart bone. There's something called the neck and the chest, right? If we don't understand that what we're talking about is enhancing these cascades, we're missing everything.
Yep. Thank you very much. Zach, what about you from your perspective on formulations or delivery methods?
Yeah, I think it's both and. I agree 100% that we need to be looking into all the terpenes and the minor cannabinoids. It's fascinating just even for the scientific challenge of it and the potential that's there. At the same time, much of what we know, virtually all of what we know about the use of cannabis comes from patients who are using cannabis and mostly combusting it. And so do we know what happens to the terpenes when they're combusted? I imagine that they transition into a very different type of medicine than if you were to take it orally. And then and then there's the synergies and the interactions amongst them. It becomes incredibly complex. So I think we have to acknowledge that mystery, not as a problem that we're a minute away from solving, but as a mystery that's probably going to be maintained for some time. And given that perspective, I think there's a value in encouraging people to experiment with different types of cannabis, different strains of cannabis. Unfortunately, it's hard to get reliable with strains these days, but if people can find what works best for them, be encouraged in a non-stigmatized way to explore carefully, to take notes, and not only is that going to help them to find an effective medicine, but it's empowering for them to become engaged in their health and become active in managing it. So I think it's both. I think we want to look at those constituents, break it down, absolutely, but also encourage people to do their own research.